Okay, so it is 11:30. I have a suspicion that we'll have a few new people joining us as I go through some of the housekeeping details. And so I will reiterate probably another time or two that for folks who haven't had a chance to fill out the pretest, that they do so by clicking in the chat box, the link in the chat box. As we're waiting for a few other participants to join us, I just wanted to provide some general information about how we'll proceed during this presentation, and then I'll give you an introduction to our presenter and we'll get started. And if I pause, I'm seeing a few new people. Welcome, Josh. I see that you just joined. If you haven't taken the pretest, there's a link in the group chat to allow you to do that. And you can do that while we're doing just some general housekeeping and getting set up for the presentation. So I'm going to get started with a little bit of background. As you'll note, everybody was muted upon entry, and we've asked that folks keep themselves muted during the presentation, as well as cameras off. That will help with the quality of the presentation. So for those of you who don't know me, my name is Naomi Wilcott-McCausland, and I am a coordinator for Bridges to Health. I work with UVM Extension. Bridges to Health, we refer to it often as Puentes internally. It's a health access program for immigrant farm workers in the state of Vermont. And we are made up of a consortium of 4 different organizations: UVM Extension, Bi-State Primary Care Association, the Open Door Clinic. There's a number of those members on the call today, and Vermont Care Partners. And so this webinar is really part of our enhanced focus that we started about a year ago on mental health among the immigrant farm worker community. And I'm really excited to do this presentation, to have this presentation offered to all of you guys today. We are a small group. There's a number of other people that did sign up that aren't on, but we do want to, for the sake of time, get started. Even though we are a small group, as I mentioned, it'd be great to just keep yourself on mute so that you know this webinar is being recorded. We've decided to do that because that will allow us to share it with other colleagues who weren't able to join during this presentation today. We do welcome questions, and the way that we would like those questions to be asked is by using that chat box that, again, is on the bottom of your screen. And you can type those questions in. The presenter will answer as much as possible as she goes along. And then there should be some time at the end as well. If for some reason she can't get to all of the questions, she will, we will work with her to send out responses if there seems to be questions that we just can't get to. It depends on how dynamic and how many questions you guys have. So as we get started, thank you again for the few people who are joining right now. If you haven't filled out the pretest, sorry to sound like a broken recorder, but there is a link in the group chat for a quick pretest. It only takes about a minute or two. I think that's the average. So please do that. And for everybody else who's already done that pretest, if you could take a moment to use the chat box and include your full name, what your occupation is, and where you work all in one chat, that will help us, and particularly the presenter, get a better sense of who is on the call today. And so I'm going to give a minute for folks to do that, and then I'll introduce our presenter. So if folks can use the group chat, so you want to make sure everybody is selected. It says to and then everyone, and then include your name and your occupation and where you work. If you are sharing computers, you can just enter a number of different individuals in one person per message, but you can just send a few quick messages. Thank you, Amy. Hi, Christine. Our open door contingent. Hi, Gillian. So I did get a question about whether or not participants could have a copy of the webinar recording, and yes, of course, you can just email me afterwards. So if folks can continue. Oh, so Gillian, it does look like you did just send me your intro. And so when you're, for everyone, as you're responding to a message, there's a drop-down menu, and just make sure you select everyone so it perfect, everyone can see it. So I'm going to get started and introduce the presenter as folks continue to use the chat box to introduce themselves, their name, their occupation, and then where they work. And that will be helpful for us as we move along. So it is my pleasure to introduce our presenter for part one of a two-part series. And so the overall arching title of this series is Culture, an Integral Part of Mental Health Services for Hispanics and Latinos. And Emily Maynard is our presenter for today. She received her PhD in clinical psychology from Fordham University. Her pre-doctoral internship was done at NYU, Bellevue Hospital Center in New York City, where she completed rotations in medical psychology, substance abuse treatment, and Spanish language inpatient psychiatry. Dr. Maynard received her undergraduate degree in Spanish and Portuguese from Princeton University with a minor in Latin American Studies. And then she was later a Fulbright Fellow to Brazil. She is bilingual in Spanish and fluent in Brazilian Portuguese. She's currently employed as a staff psychologist at the University of California, Santa Barbara's Counseling and Psychological Services, where she specializes working with students with serious mental illness and students from immigrant, especially Latin American backgrounds. She also provides Spanish language supervision to PhD trainees at UCSB. So, Emily, thank you so much for being on, and I'm gonna let you take it away.
Great. Thank you so much, Naomi. I'm really excited to be here, calling in from California this morning. Let me see, I'm trying to get used to this system. So I did put together basically the same thing that Naomi just said about me, about some of my training and background. So I've received clinical training and supervision in Spanish, and I've worked with Latino patients and supervisors from a lot of different Latin American countries, as well as from Spain. Most of my clinical training was in New York City, which primarily has a Caribbean Spanish focus, and now I live in California, which is more of Mexican Spanish speakers. But I learned Spanish in South America. I lived for a total of 3 years in Chile, Argentina, and Brazil. So my Spanish originally was more of what we call Southern Cone, and later I learned more about Caribbean and now more about Mexican Spanish. I'm happy to answer questions related to Spanish if there are Spanish speakers here too. As Naomi said, please just use the chat box in terms of asking me specific questions. Everyone's hearing me fine? Maybe Naomi?
Yes, I hear you great.
Okay. So today we're going to start out by talking about different cultural factors in Hispanic and Latino populations, which I know you all work with. And I'm going to describe the main cultural values, factors, and cultural idioms that impact Hispanic and Latino mental health, engagement and recovery, and how to identify and manage barriers in treatment with Hispanic and Latino patients. First, I'm going to start off by talking about some statistics and definition of terms. And the goal here is to provide an understanding of the current distribution of Latino populations in the US, some characteristics and possible barriers to service, including disparities in mental health treatment, and some other concepts that will be helpful for you today. And I just want to emphasize that the intention here is to provide an overview of working with Hispanics and Latinos who have mental health disorders. It's not to try to stereotype or promote generalizations about Hispanics and Latinos. We can make some generalizations, which I will be doing, but we should always remember that we're working with individuals or with individual families and that they may differ from the norm. So just to start with some terms, I will use Hispanic and Latino pretty interchangeably. When I lived on the East Coast, I found that Hispanic was preferred by a lot of my patients. And then when I moved to California, Hispanic was seen as an offensive term. So I learned pretty quickly to say Latino. But the government, for statistical purposes, uses both of them, and I'm not going to get into right now the specific differences, but they're defined as being a person of Cuban, Mexican, Puerto Rican, South or Central American, or other Spanish culture or origin, regardless of race. And the regardless of race is in recognition that people in Latin America are descended from indigenous people, Europeans, people of African descent, people of Asian descent. So there can be a lot of racial diversity. And you may also hear more and more this term Latinx or Latinx, which is a term that recognizes that Latina and Latino are gendered, which correspond to a gendered binary, whereas Latinx is non-gendered and therefore it's more inclusive of transgender and non-binary people. I've heard it pronounced Latinx or Latinx. So there are estimated to be about 57 million Latinos living in the United States right now. This is about 18% of our current population, and about a third of those Latinos were born outside of the United States. This is a fairly young group. 25% of Latinos are younger than 18. Of those younger people, most of them are not foreign born. And those who are older than 17, about half are foreign born. When we see how countries of origin or place of origin of Latino populations, the majority in the United States are from Mexico, which shouldn't be too surprising given our geographical proximity to Mexico and the fact that we occupy territories that previously belonged to Mexico in the Western United States. We also have a significant number of people coming from Puerto Rico, which is a US territory, from Cuba, and then other countries are in lower percentages. So I understand that in Vermont, you're seeing mostly Mexicans and maybe people from other parts of Central America. Please correct me if I'm wrong. And then this chart displays some changes in demographic trends that we can anticipate as our population ages and younger cohorts become older. So we can see that the older cohorts, 65 plus years old, are more white and less diverse. And then as the cohorts get younger, getting towards the 16 to 44 and even under 16, that there's a larger proportion of people in those cohorts that belong to non-dominant racial or ethnic groups. And in fact, right now, or in 2013, it was about 17% Latinos in the United States, and we estimate that by 2060, there will be about 31% of the US population that is Latino. So by participating in a presentation like this today, you are also preparing yourself for this demographic change that's happening. And just to compare some Hispanic and Latinos as a group versus non-Hispanic whites, which are often the comparison group. Overall, Latinos have a younger median age, lower educational attainment, lower median income, and you can see these specific numbers on the slide, higher poverty levels, fewer Latinos have health insurance, or that indicates that 17.8 of Latinos do not have health insurance, whereas only about 8% of non-Hispanic whites are lacking health insurance. And then a significant strength of Latinos is that many more Latinos speak a different language, whereas among whites, it shows that that 95% of whites only speak English. And this slide compares health insurance rates with Hispanics and Latinos with other ethnic groups included in the census, and we can see that Latinos and Native Americans have the highest rates of not being insured among different ethnic and racial groups. Now, despite the fact that Latinos present with lower socioeconomic status in the United States and greater disparities in receiving health services, actually their life expectancy in general and by gender is higher than any other racial or ethnic group. And this can be attributed to what's called the epidemiological Hispanic paradox, which is the idea that because Latinos report fewer risk behaviors such as smoking and bad eating habits, this is probably why they have higher life expectancy than other groups. But we'll talk a little bit about how even higher life expectancy doesn't really make up for some of the discrepancies in access to services. So it's estimated that about 16% of Hispanics and Latinos will experience a mental health disorder. The most common mental health disorders among Latinos are generalized anxiety disorder, depressive disorder, PTSD, and substance use disorder. And recently, they've noticed a trend where Latina high school girls have high rates of suicide attempts compared to other groups. And although in general, Latino communities are showing similar levels of mental illness as the general population, there are disparities in access to treatment and in the quality of treatment that Latinos receive. And this disparity can put Latinos at a higher risk for more severe and persistent forms of mental illness because, as we know, if some illnesses are not addressed early on, they can get worse and more chronic. And as a community, Latinos are less likely to seek mental health treatment. We'll talk a little bit about this too. Just in terms of comparing past year mental health diagnoses from Latinos and other groups, interestingly, we can see that there are lower rates for all diagnoses among Hispanics, which are the orange group, except for adjustment disorders. And I'm not sure which of these are statistically significant differences, but we do see slightly lower rates. And I'm just wondering, my hypothesis would be that the reason that there may be higher rates for adjustment disorders is that those are considered trauma and stressor disorders, and they could reflect the fact that Latinos face a lot of ongoing psychosocial stressors in the current political situation. So talking about your state, or Vermont, as you know, Vermont is one of the smaller states. The total population is a little over 600,000. It's about 95% white and about 2% Latino, according to a 2017 survey. About 95% of Vermonters are native born, meaning they were born in the United States, and about 5% are born outside of the United States. Now, comparing the US overall, about 13% of people in the United States are born elsewhere. And in Vermont, the largest Latino groups are Mexicans. This is in order of population: Mexicans, Puerto Ricans, Spaniards, and South Americans. About 95% of adult Latinos in Vermont are employed. However, their per capita income for Latinos is lower than the average per capita income in Vermont. About 14% of Latinos living in Vermont are estimated to live below the poverty level. And I don't have specific data about Latinos in Vermont and mental health conditions, but I do know that of all Vermonters, about a little over half of Vermonters with a mental health condition were receiving services from 2011 to 2015. And Vermont has comparable levels of serious mental illness in comparison to the overall US population. So we do see it looks like Vermont is higher than the US average. However, we don't know if that's a statistically significant difference. Any questions so far? Okay, you're welcome to put them in the chat box. I'm keeping that open. So when we talk about immigration, a lot of people are concerned about acculturation, which is how quickly immigrants can fit into the mainstream culture. And acculturation is this process where members of one cultural group adopt the beliefs and behaviors of another group. So it's interesting to note that acculturation can be reciprocal. That is, the dominant group can also adopt patterns typical of the minority group. And I noticed this when I moved to California from the East Coast, that at every child's birthday party in California, there's a piñata, regardless of whether the family is Mexican or not. So that would be the dominant group using some cultural traditions of the minority group. And some people would talk about cultural appropriation here as well. Acculturation as an area of study, it's mostly concerned with how the individual and how they relate to their own group as a subgroup of the larger society. Processes of acculturation can lead to acculturation gaps in families because younger groups tend to acculturate at faster rates than older groups. So within families, we often find different rates of acculturation, which can lead to differences in communication, parenting practices, and socialization practices. If we're working with intergenerational Latino families, it can be helpful for them to acknowledge or to educate them that this is a normal process, and it doesn't necessarily indicate that this family is severely troubled or that this family, is has more problems than other families. That in fact, intergenerational acculturation gaps are very common. And this slide looks at how acculturation level measured by different domains such as age of immigration, time spent in the US, the language someone speaks, social network, ethnic preference, and ethnic identification can actually be used to predict the odds of having depression or anxiety. And we see that for Mexicans, the probability of exhibiting depression and anxiety is higher with older age and being born in the United States, which it's really interesting. This is called the immigrant paradox, that more time in the United States is actually associated with higher rates of depression and anxiety. And that for Latinos that have less of a Latino identification and fewer Latino social networks, the odds for depression and anxiety are higher. So acculturation isn't necessarily this ideal that we should strive for. In some instances, this can be harmful because there are protective effects of being connected to one's culture of origin. One study found that among Hispanic adolescents who mostly speak Spanish, who associate primarily with Spanish speakers, and who engage in Hispanic cultural practices, that those teenagers were less likely to use drugs and alcohol, more likely to be physically active, less likely to consume fast food, and more likely to adhere to prescribed health regimens, like in the case of people with diabetes. So the message here was that acculturation could be hazardous to someone's health. And this is considered the immigrant paradox, that those with greater degrees of acculturation may have more problematic health outcomes. Now, a related idea is assimilation, which is the idea that that as people spend more time in one country, in the host country, they tend to have changes in the language preference. They tend to adopt common values and practices of the host culture. They tend to start to belong to social groups and institutions from the host culture, and they may lose a separate political or ethnic identification as they come in contact with their host society. So we see this for a lot with third or fourth generation so-called white ethnics, such as Italians and Irish, German Americans who no longer affiliate by ethnic group unless it has to do with St. Patrick's Day, or no longer speak the language that their ancestors did. And for a long time, this was the aim of US immigration policies and education policies. This was the idea of the melting pot, that immigrants should come to the United States and change to adapt and be like the host culture. Enculturation, in contrast, refers to the process of selectively acquiring or retaining elements of one's heritage culture while also acquiring some elements from the receiving culture. So this could be a sort of like, I'm going to pick and choose in which situation I'm going to speak Spanish, in which situation I'm going to act more Latino versus in which situation I should act more American or more white. And ambiculturalism is used to refer to an identity where traditional cultural values and identities exist alongside mainstream American ones. And whereas the term bicultural may imply a cultural division or a split, ambicultural Hispanics are completely comfortable being fully Latino and fully American. They can move between these two identities with effortlessness without sacrificing or questioning their attachment to either. I just have a quick video that I'm going to show from a movie that some of you may have seen. Wait, it's not going to let me. Let me just change my share. Okay. Are people seeing the movie now?
Listen, Anglos jump all over you.
We need more volume though.
Oh, I don't think I can turn up the volume on the movie. Can people turn it up on their own computers? Oh, darn.
Listen, being Mexican American is tough. Anglos jump all over you if you don't speak English. Mexicans jump all over you if you don't speak Spanish. You gotta be plus. Why are you laughing? What's so funny? I'm serious. Our family has been here for centuries, and yet they treat us as if we just swam across the Rio Grande. I mean, we gotta know about John Wayne.
Okay, it sounds like it's hard to hear it, right? Okay. I'm going to send the link later for people to watch then. Let me just get to where it was. I'm sorry that you can't watch that today. It's a short clip from the movie Selena, and it's about being Mexican American and navigating the tensions of being bicultural or ambicultural. So now I'm going to talk about cultural values and specific idioms of distress in Latino populations. Going to help you think about how to integrate cultural values and idioms of distress in mental health treatment with your patients. I'm going to describe cultural competence and responsiveness that can help the provision of mental health services for Latino populations living in the United States. I'm going to talk about Latino cultural values and describe how they can influence the view of mental health conditions. I'm also going to explain Hispanic and Latino cultural idioms of distress, their utility in mental health treatment, and how to incorporate them as part of your assessment and intervention. So cultural responsiveness is defined as being able to understand and to consider the different cultural backgrounds of the people you teach and offer services to. Culturally responsive services will offer clients the chance to explore the impact of culture, including historical and generational events, acculturation, discrimination, and bias. And culturally responsive services will allow patients to examine how these may impact or affect their mental and physical health. For instance, by providing therapy sessions in Spanish or using an interpreter. Some principles for culturally competent treatment services for Hispanic and Latino populations are to demonstrate and gain knowledge about the culture, including cultural values. And part of your participating in this presentation is to do that, is to gain some specific knowledge about Latino cultures. Also, I think when we do something like that, it makes us more aware of our own attitudes, our own beliefs, biases, and assumptions about others. Here specifically, we're going to talk about cultural idioms of distress that can help us in case conceptualization and in providing mental health services. So I have some questions that we can ask our patients that can open up discussions about culture in therapy sessions or in treatment sessions. And I'd be happy to share the specific list. But some of these questions are like, where were you born? Whom do you consider family? What was the first language you learned? What other languages do you speak? And what language or languages are spoken in your home? What is your religion? How observant are you in practicing that religion? What activities do you enjoy when you're not working? How do you identify yourself culturally? What aspects of being Mexican or Guatemalan or Salvadorian are most important to you? How would you describe your home and neighborhood, and whom do you usually turn to for help when facing a problem? I'm going to go through some traditional cultural values that sociologists and anthropologists, as well as psychologists, have identified as being important in working with Hispanics and Latinos. And as I already noted, that Latinos may be acculturated at different levels, and so differential rates of acculturation can change the emphasis that your patients place on traditional values. So they may be more or less significant to the individuals that you work with. So I'm going to talk about family first, or familia. For almost all cultures, family is important, but I want to describe how it looks for Latino families. In the case of immigrants, if there's no family immediately in the area, they may still closely connect with other individuals from their town or area where they immigrated from. Or they may connect closely with individuals that their extended family knows, even if they didn't know that individual personally before moving to the United States. In Latino families, it's common that all individuals, including adolescents, are expected to support the family financially and to support each other during hard times. And for immigrants, this often means sending remittances back to their family of origin. Familismo describes how the Latino client will focus on family and their community group as a source of identity and support. Some Latinos report that they don't have a lot of friends outside of their family or extended family or close family friends. That's very common. And in Latino families, it's also usual that individuals will frequently consult other family members regarding decisions, and mental health or health providers who don't recognize the importance of family in working with Latinos may encounter conflicts with their patients and may find that their patients don't follow through with treatment recommendations. And so we might, if we're used to working from a more Anglo perspective, which is where the goal of a family raising a child could be to have the child become very independent as an adult. That's not necessarily a goal of most Latino families. The goal would be to raise a child who can give back to the family and remain connected to the family. And if we look at this from a more Anglo lens, we might say this sounds like an enmeshed family system, and we may try to get our patients to become more independent from their families. And this will be inconsistent with their cultural values and will probably lead to an interruption in treatment, because they'll say, this clinician doesn't understand me. I have to support my uncle back in Mexico. Like, this is not a strange thing. And research has demonstrated then that when mental health providers who primarily serve Latinos use a more flexible understanding of boundaries and view families more holistically, that there are better outcomes in treatment. One way we can do this is to involve family members early in care, or to ask our patients questions like, what would your mother say? What would your spouse say? And this can help build trust with our patients. So respeto, or respect, refers to respect given to professionals and other people in authority based on their position. Latino individuals tend to expect status differences between professionals and non-professionals, which is different than a more egalitarian position in the United States. So there's a high value placed on demonstrating respeto in interactions with others. And this can lead to Latino individuals being hesitant to ask providers questions or to express concerns about treatment recommendations, because they may fear that it's disrespectful to question the doctor. And we can help work around this ourselves as clinicians by naming common concerns that our patients have, like saying to the patient, sometimes people are concerned about side effects from this medication. And this is a way to normalize these concerns and to open up some more conversation about treatment preferences and adherence. Respeto is also expected on a reciprocal basis when healthcare professionals are working with older Hispanic or Latino professionals. And the expectation is that younger healthcare professionals should behave in a formal manner. So that would mean I actually just do this as a matter of course. I would always refer to Latino patients using the formal form of address, usted, until they tell me that I could use tú or vos. And I would also always refer to them to adults as señor or señora or Mr. or Mrs. This is seen as a sign of respect. Any questions so far about some of these specific cultural values? So personalismo or personalism is another cultural value, and I love this definition of it as formal friendliness. So this refers to how someone should behave within relationships, including professional relationships, where Latino patients may expect healthcare providers to demonstrate simpatía or friendliness and personalismo. So when these values are not expressed, the Latino patient may feel slighted or feel that the healthcare professional didn't provide good service. And this may lead to lower likelihood of compliance in treatment and in recommendations. So I often find myself using maybe smiling more, maybe being a little more openly affectionate towards patients that I've worked with for a long time. Also using judicious self-disclosure about my own life in order to enhance this personal feel. And sometimes when Anglo providers first work with Latinos, they think, oh, they're not boundaried, or, oh, the patient is asking me personal questions. And what I usually find is that they are boundaried, but it's a different level of the boundaries are in a different place. And they may ask some personal questions like, are you a parent? Are you married? And usually they wouldn't go much beyond that. So they were just want some kind of answer to show that you would understand them, that you might have something in common with them. And so I'm usually very open in answering that kind of question, and I've decided for myself where my boundaries are. So I will also explain to Latino patients why I speak Spanish. I don't make it a mystery. Also, when I work with Latino families, they will often ask me if I'm a parent, and I'm happy to say that I am. Whereas that's a question that sometimes more traditionally trained North American clinicians maybe have the tendency to say, "Oh, why do you ask that?" or put it back on the patient of like, "Oh, it's interesting you would ask me that question. Why does that matter to you?" And they're asking that question because they want to feel a sense of connection with their clinician. They want to feel closer, and they aren't going to follow up necessarily. Like usually they don't follow up with a lot more personal questions. It's kind of a formality, like, oh, just want to know this, and then they move on. This is related to confianza, to trust. And so interestingly, within European and North American cultures, there's less of a reliance on trust in specific individuals that we work with. And there's more of an importance placed on codes of ethics, professional conduct, and explicitly stated rules that dictate how we as professionals will behave. And this is not to say that in Latin America that there aren't codes of ethics and rules of how professionals behave, but that also there's an expectation that there will be trust between individuals, and that this personal relationship between the provider and the patient is expected, that the provider cares about the patient beyond their professional role. And again, small self-disclosures can be helpful in establishing trust. It can be humanizing to disclose something like, oh, I struggled with learning Spanish, when the patient is struggling with learning English. So another cultural value is spirituality or espiritualidad. And many Latino individuals are very spiritual and religious. And the most representative religion is Catholicism, but there are also Protestant Christian practices in Latin America. There are Jewish Latinos, there are Muslim Latinos, there are Buddhist Latinos. So we shouldn't assume that everyone's Catholic. Within some of the Catholic beliefs, there's this idea of fatalism, which is the belief that the individual can't do much to alter their fate, that God is working and determining the outcome. And because of this fatalist orientation, some Latinos are less likely to seek treatment for their symptoms. And they also might decline newer or more aggressive therapies because they see this as being in the hands of God. Latinos are also able to tolerate more uncertainty than the majority culture in the United States, and they're more comfortable with the unknown. An example of this kind of relying on God was a common phrase that I would hear my Caribbean patients in New York say is when I would say, okay, I'll see you next Wednesday at the same time for our appointment. And instead of them saying, yes, I'll see you next week, Wednesday at 3, they would say, si Dios quiere, or if God is like God willing, I will see you. And at first this really annoyed me. Like, what does God have to do with it? We have an appointment at this time. But then as I began to reflect more on these religious practices and the fatalism and the fact that in some of these countries, there can be a lot more unpredictability in people's daily lives where people may not be able to count on public transportation to get them to a hospital on time. So this idea of, well, if God willing, I'll be there is just more of a reflection of, well, I can't absolutely confirm that I'll be there. I'll do my best to get there. And in addition to fatalismo, individuals from this culture could also have a lower drive to access and manage their own health care because of this belief that what happens to them is in the hands of a higher power. So for some Latinos, routine or preventive care appointments won't make as much sense to people who believe that fate or God is in charge of their health. On the other hand, spirituality can be very helpful as a source of support, as a source of meaning for Latino patients, and often joining a religious community in the United States where other people from their country of origin or other people who speak their language are involved can really help people with adapting to life in the United States. So within some spiritual practices related are some traditional healing practices that are common across Latin American groups. For Latin Americans from Mexico and Central America, you might hear about curanderismo or curanderos, who are traditional healers. In other parts of Latin America, like in the Caribbean, we hear more about espiritistas or santeria, it would be voodoo in Haiti, or brujos, which are witches. And I'll talk in more detail about some of the illnesses that they may work with, but some of the names are like susto, empacho, mal de ojo. Susto is a kind of fright. Empacho is like a digestional blockage, and mal de ojo is an evil eye. So it may be the case that before a Latino patient, especially one who's not very acculturated to the United States, before they access formal healthcare services, they may have already consulted with a folk healer. There are also yerberos, who are herbalists who would prescribe specific herbs or plants. And all of these healers will perform things called as limpias, or cleansing, to get rid of negative forces or to address problems like the evil eye. Among Mexicans, we also see sobadores, or traditional massage therapists. Sometimes these practices are secretive, and sometimes patients know that they're not established treatments, and they may be reluctant to disclose to a practitioner that they've consulted someone else before they work with the more formal professional. But a lot of times Latinos only go to a doctor when something is really wrong and when pain is unbearable. So more traditional Latinos will be more likely to consult these traditional healing practices first. So idioms are local linguistic or nonverbal modes of communication. Suffering is expressed in a particular way across cultures. We're going to talk about common cultural idioms of distress in Latino populations. So distress can be related to acculturation, discrimination, oppression, or stigma. And during the therapy process, a culturally responsive clinician can explore the meaning of the patient's expression of distress in order to provide more effective treatments. It may be easier for Latino patients to say, for instance, that they have nervios, which we'll describe in a little bit, than to describe themselves as having a major depressive disorder or a social phobia. So there's more attention in the DSM-5 than in previous editions of the DSM to cultural concepts of distress, and there are three main concepts. Cultural syndromes, which are groups of symptoms and signs that co-occur among individuals in specific cultural groups, communities, and contexts. There are cultural idioms of distress, or ways that symptoms are expressed, which provide a collective, shared way of experiencing and talking about personal and social concerns. So one American idiom of distress would be just saying, I'm so stressed out, or I'm overwhelmed, where if we think about it, that doesn't describe a specific situation or a specific emotion, but it's an idiom of distress. Some medical anthropologists have often also written about how lower back pain is an idiom of distress among North Americans, that people frequently present with this vague lower back pain when they experience a lot of social and work-related stress. Cultural explanations are perceived causes of illness. They're the labels, attributions, or features of an explanatory model that indicate the culturally recognized meaning or etiology for symptoms, illness, or distress. Why does this happen? So again, idioms of distress are the ways in which a specific culture expresses suffering, and they matter when a provider wants to provide culturally sensitive treatments. And they can be an expression, a culturally specific expression of DSM diagnoses such as generalized anxiety, depression, dissociation, PTSD. So nervios or nerves is a general state of vulnerability to stressful experiences. This is a really broad term that may include some somatic symptoms. And there are different levels of nervios that can indicate a worsening of symptoms. The beginning of the spectrum would be to ser una persona nerviosa, or to be a nervous person. And then to suffer from nerves or padecer de los nervios would imply more pervasive symptoms. Then we would have ataques de nervios, attacks of nerves or nervous attacks that are more severe and can include violent acts towards others, somatic distress, or loss of control of behaviors. And it's believed that extremely severe nerves could lead to locura or madness. And often people with nervios report that they have thoughts that are stuck in their head, and we would call this perhaps rumination. But nervios can also present with symptoms like headaches, muscle aches, sadness, difficulty sleeping. Whereas an ataque de nervio is a more specific time-limited nervous attack, and it's characterized by symptoms of intense emotional upset, which usually occur in an interpersonal context. And it can include anxiety, screaming, shouting, crying, trembling. It can include verbal and physical aggression towards others, experiences of depersonalization or derealization, and partial or complete amnesia for the episode. People often experience a sense of relief after an attaque. And this idiom of distress typically includes physical health problems, including neurological complaints and other impairments that are not common in related psychiatric disorders. So often these are compared to panic attacks. But in panic attacks, we usually don't have the partial amnesia or the physical aggression towards others. Risk factors to experience ataque de nervios are being a woman over 45 years old, being formerly married, having less than a high school education, and being unemployed. So susto is a cultural explanation for distress and misfortune that's prevalent among Latinos in the US and among people in Mexico, Central America, and South America. It's not used in the Caribbean to describe distress. It is an explanation that for illness that attributes, it says that there's been some frightening event that causes the soul to leave the body and results in unhappiness and sickness, as well as difficulties functioning in key social roles. And the symptoms are frequently, I said unhappiness and sickness. This can be linked with increased stress and physical distress, and it's typically related to a particular incident. And incidents that cause susto frequently have a thread of helplessness involved against, and again, this is the sense of fatalism, like if God willing, I'll get better. And these are just some of the symptoms that people report with susto: appetite disturbances, inadequate or excessive sleep, nightmares, feelings of sadness, low self-worth or dirtiness, interpersonal sensitivity, and lack of motivation. I just want to make a comment about the cultural idioms of distress, because these often seem very colorful, very like, wow, I haven't seen this before. And in a lot of ways, they overlap with the common DSM diagnoses. In other ways, they're different. When working with more acculturated Latinos, for instance, when I work with the college students that I work with that are usually the children of immigrants or came to the United States as a young age, I don't see a lot of these cultural idioms of distress. I see a more American presentation of stress, anxiety, panic attacks. Okay, I'm going to move on to risk and protective factors, but before I do, are there any questions about the cultural idioms of distress or incorporating knowledge of this in treatment? Okay. So I'm going to talk about risk and protective factors in working with Latinos. Risk factors are defined as characteristics at the biological, psychological, family, community, or cultural level that precede and are associated with a higher likelihood of negative outcomes, whereas protective factors influence the individual behavior by reducing or lowering the likelihood of negative outcomes. So now we're looking at this from more of a public health or epidemiological perspective, talking about risk and protective factors. And in general, we talk about two types of risk and protective factors. We talk about variable factors that can change over time, like income level, peer group, employment status. Ones that don't change would include genetic predisposition or vulnerability. And unfortunately, having some risk factors makes you more likely to experience other risk factors and lower protective factors. So there's kind of snowball effect. If you have some risk factors, not good, but then you may also have more risk factors in the future. And so because of this, we should be aware, we should try to focus our interventions on increasing and enhancing protective factors. So the social determinants of health are conditions in the environment in which people are born, grow up, live, that affect health functioning and quality of life outcomes and risks. These circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels. And these social determinants of health are mostly responsible for health inequities. So the unfair and avoidable differences in health status that are seen within countries and between countries. I'm going to refer to Bronfenbrenner's social ecological model, which those of you who have studied public health or psychology may be familiar with. It's a way to think about interrelated levels of relationships, starting with the individual, relationships, community, and social level. Individual factors can include things like age, education, income, substance use, history of abuse, or genetic components. The second level includes relationships such as family, peers, friends, partners. The community level includes institutions and like schools, workplaces, neighborhoods, and churches. And the societal level may include social and cultural norms about mental health and also include health, economic, educational, and social policies that help to maintain economic or social inequalities between groups in society. For instance, if a state does not let undocumented immigrants have health insurance, that's a social policy that helps maintain economic and social inequalities between groups. So I'm going to go through each of these risk factors at the different levels. This is just an overview of what we'll see at the individual and the relationship level. The social ecological model will consider the complex interplay between the different levels. And this can help us understand the range of factors that put people at risk for mental health conditions or protect them. So at the individual level, we have language barriers, low educational or financial status. The relationship level, we have acculturation stress and acculturation gaps. Community level, we have stereotyped gender roles, disparity in service access, social norms and context, and finally at the societal level, we have things like racism and structural inequality. So individual level, language barriers. This is one of the main causes of stress in getting services, accessing housing, physical and mental health, insurance, and other community resources. So language usage can also indicate acculturation or assimilation levels. And in the United States, there have been recurring concerns about immigrants and their inability or unwillingness to learn English. But research is very clear that there's consistent language assimilation within a generation for immigrant groups. And even Latinos, who are frequently charged as being the most resistant to learning English, they are also acquiring fluency within a generation. One survey found that 96% of foreign-born Latinos reported that it was important for their children to learn English. Regardless, providing services in Spanish or interpreting services for Spanish-speaking patients can increase engagement. I should also mention that language barriers can be a risk factor for children too, because children are sometimes used as language brokers to translate for their parents at schools, mental health services, or medical offices. And sometimes it can be re-traumatizing for children and to the family to have children exposed to some of the material that their parents are talking about. So in terms of educational level and financial status, as I already mentioned, Hispanics reported the lowest percentage at every level of education, from lowest percentage of high school graduates or more, and lowest percentage of racial or ethnic groups earning advanced degrees, only 5%. It's common among recent immigrants that they are working 2 or 3 jobs to pay bills in the United States and to send money to their family members in their home country. Because of financial status and lower education, Latinos may have difficulties finding and connecting with free and community-based services. And as health providers, we can develop a list with resources where clients can find free food, legal advice, transportation, medical insurance, furniture, and other resources. So Acculturation stress can include changing from one country to another, learning a new language, changing a home, moving from owning to a home to renting, changing work, moving away from the family. And these stresses can lead to mental health problems. We can also think about acculturation stress from the perspective of loss and grief. That Celia Falikov, who's an Argentine psychologist who works in California with a lot of Latino immigrants, has discussed immigration as an ambiguous loss because you both lose and don't lose the country of origin. But often there's a grieving process that comes along with immigration. And we already talked a little bit about discrepancies between parents and adolescents in terms of acculturation, and parents will experience stress trying to understand second and third generation immigrants in terms of the differences in cultural values. Another source of mental health risk factors are stereotyped gender roles. And I want to avoid us thinking about this as being specific to Latino cultures, because in the United States, we certainly have stereotyped and unhelpful gender roles as well. We may not call it machismo, we might call it toxic masculinity or male chauvinism, but this is not unique to Latin America. Motherhood. So in most cultures, motherhood is a sacred status, and it's especially important for Latinas to be mothers and to have this role recognized. Often being a mother as a Latina is reflected in self-sacrifice for the family. But Latinas who have left their sons and daughters at their home countries can experience a lot of guilt and stress and depressive symptoms in being separated from their children. In terms of machismo, this is a form of masculinity that involves having pride, being courageous and valorous, which are positive attributes, but it also promotes male dominance and superiority. And studies have found that men who more highly endorse the value of machismo are more likely to be functioning alcoholics or drug users. They may go longer without mental health treatment with the goal of avoiding asking for help. And what can be useful is when a provider maintains a stance that's accepting of strength and weakness and provides respect to the client at all stages of illness. Machismo may also lead men to minimize their symptoms, to not use familial support, or to stop treatment prematurely. So lack of health insurance is one of the major barriers to mental health services in the Hispanic or Latino community. We also have perhaps low levels of health literacy because of low education levels and because of linguistic differences. And health literacy is defined as the degree to which the individual has the capacity to obtain, communicate, process, and understand basic healthcare information and services to make appropriate health decisions. Because of language and also different conceptualizations of health and wellness, there can be poor communication with health providers due to linguistic and cultural factors. Other individual barriers in seeking mental health treatment can include the stigma of mental health or mental illness and the lack of recognition of mental health problems. So I work with a lot of Mexican American students who are the first in their family to ever seek therapy and who say, my parents don't believe in mental illness. So in terms of social norms and contexts, many Latinos live in a situation of social marginalization. They may live in poverty, have low education, lack of access to services. They're also in a context in which they're policies designed to discriminate against them. There's institutional racism, and then aversive daily interactions with people from the dominant culture. And these can all shape expression of mental illness. So another aspect of these social norms is discrimination. and how this can lead to more psychosocial distress. Other levels of distress can be caused by high community violence in poor neighborhoods, intimidation by police officers, and often reluctance on the part of Latinos to reach out to the police when they have when a crime has been committed against them because of fears of police response, sometimes fears that the police will report them to immigration. So these are an example of the psychological stressors that a Latino day laborer can face. And this was part of a study where day laborers in North Carolina were asked about health and well-being. And the question was, do you worry about your health? And this man said, yes, we worry about our health and our family because right now I don't know if my family back home has food on the table or not. And then I can barely sleep because I'm thinking about my family, and it's even worse when someone's sick. You worry even more. You aren't working and my son is sick. You feel like your head is going to explode, but what can you do? There's nothing you can do. So this can lead to this sense of helplessness and powerlessness. And then at the societal level, we have racism, which leads to oppression, institutionalized racism leading to anti-immigrant laws, and policies that discriminate against Latinos. Racism is the ideology that one race, namely white European, is superior to another race, and it's based on skin color and appearance. Ethno-racial trauma is defined as the collective or individual fear after experiencing or witnessing discrimination, such as in the media, or threats to harm, violence, and intimidation directed at ethno-racial minority groups. For example, even if a Latino doesn't personally experience discrimination in their community, if they see on the news reports of people who look like them being targeted in immigration raids or police stops, that can contribute to anxiety and depression, and that would be ethno-racial trauma. I have a video that I wanted to watch about race and stigma, but I'll send you the link so you can watch it. So we've been talking about risk factors, but now I'm going to talk about protective factors because as we've seen, despite a lot of risk factors, Latinos actually have lower levels of mental illness than other groups. And this can be explained in part by their robust protective factors. And having protective factors doesn't mean that a person isn't going to pass through difficult experiences, but the protective factors will be like an umbrella that protects you from the rain. It doesn't mean it's not going to rain. It just means that even if it rains, you have the capacity and the ability to protect yourself. So protective factors influence individual behavior by reducing or lowering the likelihood of negative outcomes. There can be individual self-protective factors like self-image, self-control, and social competence. And I'll go through some of these other levels of protective factors. At the individual level, we have cultural identity. So we saw that Latinos with a higher sense of cultural identity reported fewer depressive and anxiety symptoms. And this can include having a sense of oneself as being Mexican, as belonging to a certain religion, speaking a certain language, could be expressed in the food, the holidays that someone celebrates. And questions we can ask our patients would be like, how do you self-identify in terms of race and ethnicity? How do others identify you? And some of you may have had some exposure to cultural identity development models. This is a model of how people from a minority culture develop a sense of identity vis-a-vis the dominant culture and their own culture. Religion and spirituality are great protective factors for Latinos and other groups. Usually religious leaders in the Latino community tend to be community leaders and very influential. Religious communities provide connection with other Latinos. Spirituality can inspire hope. in the future for the patient. And it's important for us to respect traditional healing approaches, which do work well for a lot of problems. Even, we might say, oh, it's a placebo effect, but a placebo is still an effect. So another great protective factor is the family, is familia. And in Latino families, usually family roles are very clear. Parents are considered the authority, and the structure of the family will define the roles, the rules, and the responsibilities. And it's important for us to consider interpersonal relationships during our interview processes, even if we're working with an individual. So asking questions about who they live with, who do they consult with for important decisions, who do they take care of, and expect that they will be consulting family members about mental health conditions. So you might ask them, what does your husband think about this? What would your son think is the cause of this problem? So this is returning to this idea of respect in relationships, that this can be, these are ways that we can help Latinos be engaged in the therapeutic process by showing respect, by using personalismo, by showing this warm and personal interest to increase engagement in the therapeutic process. And if we demonstrate kindness towards our patients and are friendly, I think this shouldn't be a surprise. It applies to people that aren't Latino as well. This will increase the likelihood of compliance with our treatment and our recommendations. So I just have a picture here of my office, which is a way that I share a little bit about myself with my patients. So because I am not Latina and I'm not Latina presenting, one way that I signal that I have an engagement and a commitment to this culture is by having items in my office that demonstrate that. So for instance, I have the map of South America where I have lived, but I also have this colorful map of the states of Mexico where a lot of my patients come from. So often when I'm asking them about where their parents are from in Mexico, I don't just stop with the question about Mexico. I say, what state? And then they'll look over at the map and they'll be like, oh, they're from Jalisco or they're from Chihuahua. And we'll kind of look at the map together. And there's this shared understanding that I know that there are different states in Mexico and I have some familiarity with Mexico. I also have an image of the Virgin of Guadalupe. I'm not Catholic, but that's a very important cultural image for Latinos. And then in terms of my cultural identity, I have a photo of a beach in Maine where my parents live. My family's from New England. So that's like my personal, history is Maine. I have a Black Lives Matter sticker here, and I also have a poster that says resist. And so I am taking a political stand rather than a neutral stand because I need my patients to know that I'm not neutral about the current administration. Because in my mind, to be neutral as a white person would be to collude with the status quo and to support oppressive institutions that are hurting my patients. I also have a few other items here that are hard to see, but I have a little flag that says sana sana culita de rana, which is this Spanish phrase that mothers will say to their children when they get hurt. It's like heal, heal, frog's tail. And I have some Spanish language dictionaries on my shelf as well because I'm continually improving my Spanish. So as mental health providers, we need to focus our interventions and treatment on increasing and enhancing protective factors among our patients. And to be aware of both risk and protective factors at the same time. So I've already given some examples of how to heighten the protective factors and how to work with some of the cultural values. So for instance, in terms of working with patients who don't ask questions about treatment or don't express concerns, but then later you find out they're not following the treatment recommendations, one way to sidestep that is to give the patient examples of common concerns that people have, rather than asking them if they have any concerns, because they'll say, no, 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 doctor, this is fine, this is great, and then they don't take the medicine. I also mentioned involving family members in treatment decisions to promote adherence to treatment. And using strong family bonds and perhaps the patient's responsibility to others. Like, oh, it'd be hard for you to work if you don't get better, right? And your family is depending on you to help motivate them to be in treatment. And then we also talked about using more personal touches with Latino patients. So before the next seminar, I'd like people to watch this video, which is on the cultural formulation interview. This is included in the DSM-5. And it's a different approach to conduct intake interviews with patients, which really puts cultural factors first and foremost. And what I love about using this approach in meeting patients for the first time is that I find I actually can draw a lot of information about symptoms and illness presentation while also being very culturally sensitive and informed. So this video is a seminar that's given by the person, a psychiatrist at Columbia Presbyterian in New York, who helped develop this cultural formulation interview in the DSM-5. And that's the end of my presentation for today. So I haven't heard a lot of feedback during it, so I'm really open right now in the 10 minutes we have remaining to answering any specific questions or concerns that you have. Okay, so Naomi asked, when we ask farm workers about sadness, anxiety, etc., they sometimes say that they frequently experience one of these concerns, but qualify their answer by saying that it's because they currently live far from home and family, and that they'll be better once they go home. So they aren't interested in mental health supports. Ha! So I'm thinking, so what is the question? Is it how to engage them in care, or? Okay. So I think I would validate that just how difficult it is to be far from home and family, and that it's understandable that they would be experiencing whatever they say, sadness or stress or anxiety, and that, yes, they might feel better when they go home, but they aren't going to go home for a while, right? And so in the meantime, they might benefit from having some other supports here. And the supports, the intervention may not be having them come back for therapy. The intervention may be getting them connected to community level supports, getting them connected to Latino community organizations or a church or a social group, rather than the traditional therapy. Or it could be framing therapy as much more focused on problem solving and more of like a case management approach, as kind of a buy-in of like, well, why don't we come back and talk about what are some ways what you can do right now as long as you're here, because you'll be here for the duration. How does that sound, Naomi? Yeah, with the problem solving, I often find, especially with Latinos that have never accessed mental health services and that have this idea that it's for people who are loco, which is like a very severe form, like a psychotic illness, that framing it as let's solve some problems, let's have a short-term approach, can be really much more engaging than saying like, you need therapy and I'm here to give you therapy. And we know that that can be therapeutic. We know that just having that person to sympathize and to listen and to reflect back to them how hard that is, that can be really helpful. And I also find, like, having worked more in a community level, with community organization with Latinos, that there may be more of a dipping in to use services and then a dipping out. So less of a consistent use of weekly psychotherapy among some Latinos, and more of a like, let me go when I have a specific problem. And if your institution is able to tolerate that kind of inconsistent use of services, that can actually be very helpful in getting them to come in, because they see you as, oh, when I had this one problem, I went and I talked to this social worker and they were so helpful, but I didn't need to talk to them every week. I just went for one problem. And what I've found is then they tell their friends, like, oh, if you have, like, why don't you go and talk to the doctora about this? And when I was working at a after school program with Latino teens a couple years ago, I was like a drop-in psychologist. I ran a mother's group in Spanish, I ran a teen group in English, and then I had drop-in hours, which were like people could come and consult with me, and that's how they often wanted to have it, was just they didn't want a weekly commitment. They just wanted to know that they could occasionally come and say, I'm having a problem with my son. What do I do? And then some of those people ended up becoming longer term, what we'd say longer term therapy patients, but it was after they already had this established relationship with me. So that is also that importance of the relationship and the trust, and that they found they were kind of testing me out, like, okay, I'm going to ask you a few questions about this, and then once they trust me, they're like, oh, maybe I do want to talk to you again. Maybe I'll bring my daughter in for her fear of the dark or something like that. So, Josh, your question about the prevalence of anxiety and depression, usually those data, that's a good question, is whether it represents a difference in people having anxiety or depression or being diagnosed with anxiety and depression. And I believe most of these data are drawn from community epidemiological surveys, which use an assessment questionnaire called the Structured Clinical Interview for Diagnosis, which asks people in the community about specific mental health symptoms. These people may not have been previously diagnosed with anxiety or depression, but they participate in this survey, and then the interviewer determines if they meet criteria for anxiety or depression. Does that make sense? Okay. Thanks for the questions. Sure.
So we're not seeing other questions, but certainly if you're in the process of writing a question, please finish writing the question while I just make some wrap up comments and we'll answer those. So a few final notes. I am going to put a post test in the chat. I know a bunch of people were on shared computers, and so you do have to open this up individually, so you can copy it from the chat, or I can send it out also in an email as well. Please do take a moment to respond to that. And then also Emily mentioned the session 2. We do have another session that will be a complement to this. Certainly if there's other individuals who didn't participate today but want to participate, we would welcome that. The next session will be on August 5th, which is again a Monday from 11:30 to 1. It will also be recorded, so if you aren't able to participate, but you do want to watch it, please let me know. And after we've had the session, I can send that out. Again, this webinar was recorded, so if you know of someone who wasn't able to attend but would like to view it, please just have them send me an email, and I'll post my contact information also in the chat box for everyone. And then it doesn't look like anybody else has added any additional questions. So thank you very much to Emily for the insightful presentation.
Very welcome.
And thank you to all of you as participants. And one more message from, just a thank you from Julia. Thanks for participating.
You're welcome.
And have a great rest of your day. Will we have a chance to see this presentation on our own? Yes, so what I can do is I can send out if you received an email from me this morning, it means that you're on my radar. That was an email about 10 o'clock or so with a link to the pre-test. And if you did, I'll send the link to a file transfer for this so that anybody who's on the call can access it. But if you weren't on that email, it means I don't have your email. So email me at the email address that I put in the group chat box. That sounds good?
Naomi?
Yes.
In terms of the links to the videos, the ones we couldn't see as well as the one for next time, can I reply all and include those links?
Yes.
Would that be a good way to share the information?
Yes, and then if anybody else on this call was not on that email this morning and emails me separately, I'll make sure to forward those links to you.
Great.
All right. Well, thank you everyone for participating. And we will hopefully see you next month for session 2.
Yeah.
Have a great day.
Thank you.
Bye.
Bye.